Our final session is Rural Rare Healthcare, which will be led by Shobana Kubendran. Please welcome our next panelist.
Hello. Oh, wow, that is louder from this side. Hello, everyone. Oh my gosh, thank you so much to Global Genes for this opportunity to organize a session on rural healthcare. I'm Shobana Kubendran. I'm the genetic counselor and manager for genetic counseling at the University of Kansas Health System, and truly a privilege to have this session as part of Global Genes. It just personifies why we're here as far as getting access to all the information, clinical trials, research, access to care. So we're going to end on a good note, hopefully. So for all of you here for the very last session, I thought I'd switch it up a bit to start. We want to hear the audience questions first. So just kind of a show of hands, because this is about rural, just kind of show of hands. How many of you live less than 2 hours from a genetic center versus greater than 2 hours? I want to see who was motivated to stay till the end on rural care. Show of hands, greater than 2 hours from the nearest genetics facility. Less than 2 hours, the majority, I guess. Okay, very good. And then as far as, one of the things I always do as a genetic counselor when I'm starting a session is I always want to know what are the questions that we want to address as we go along. So we have a set of questions, obviously, but I would love to hear, for those of you motivated enough to stay here till the very end, I know you must want to learn something about access to care, rural health care. Just a show of hands, anybody with any questions or any curiosity, what you hope to learn from today's session.
There we go.
And we'll make sure to answer those questions as we go along.
Hi, my name is Danny Sun. I'm a social worker in southeastern Wisconsin. So we have a lot of rural areas in western and northern Wisconsin. And my inclination when trying to think about how best to outreach to people in rural communities is that I need to reach out directly to those clinics there, try to get in touch with the state newborn screening labs and trickle the information down that way. And I'm curious if there are other avenues that I'm just not thinking about that you all have recommendations for. Absolutely,
yeah. These are the experts on access to services and all the other avenues. So before we get, any other questions? Any other curious ones? Oh, there we go.
Hi, I'm from Heber City, Utah, so it's pretty rural, and I'm running into complications with getting service providers to accept my insurance. It's all private pay, and there's no guarantee that I'll get reimbursement for it, so I'm just wondering, do you guys have a plan on that? And then on top of that, because we're in a rural area, it's really hard to get the specialists that we need, so I'm on everybody's waiting list with no end in sight of when I might actually be seen.
Okay, absolutely. That ties in with one of our last couple of questions, so we'll make sure to address that as part of it. Okay, so we've got access to care, insurance, genetic testing, so we'll talk about all of that. So a little bit about me as a moderator for the session. I've been in Kansas for 15 years. And what really got me into access to care is, as you guys have alluded, the long wait list. No matter how many patients I add to a day, I am not going to decrease that year-long wait time. So I started working on different ways to increase access in primary care through genetic testing and counseling. How do we integrate some of that? And with this panel, even more experience. So I want to introduce Dr. Anna Cohen. She's a researcher and lab director at Children's Mercy. Fantastic lab. It is one of the best labs that is conducting some of the most upcoming research into different types of diagnostic methods that are not even in the clinical space, but definitely in the research realm. So look them up on their website. So Anna brings a very unique blend of clinical and research focus, where she analyzes exomes. So exomes are the tests that look at all the protein coding regions of the genome for sick children, especially the ones in the NICU, neonatal intensive care. So, but beyond that, she's interested in increasing access in just really across the Heartland region. And for that, she has started an initiative to partner with primary care providers in rural clinics. So bringing some of that high-end technology that is at Children's Mercy and increasing access to that in primary care, cutting-edge genomics. So that is very innovative for this region. And that has definitely, as part of that, including models of access that address disparities in care across the geographical region. So we're excited to hear that more. And then next is Dr. Nadia Falah. She's a clinical geneticist at Johns Hopkins All Children's Hospital. And particularly her work in West Virginia to address the barriers in care in the Appalachian region. During the pandemic, Dr. Falah's work in telegenetics provided crucial insights in how to overcome those access challenges. So for those questions about, are we thinking about other avenues, Dr. Falah will be able to address those. And then she's also worked on the West Virginia Rare Disease Consortium and developing that access through research. So glad to hear about those insights. And then Dr. Elias Abdallah, Chief Medical Officer at Shodair Children's in Helena, Montana. So he leads the only comprehensive genetics program in the state. So I think probably knows the challenges more so than any of us here. And so his clinic and lab services are across Montana, including Wyoming, Idaho, and parts of Dakota. So his, it's really like, how do I expand access across different states? And so through that work, he's also worked with the American Indian population, so very uniquely positioned to talk about access and barriers to care. So we wanted to open up to, Dr. Cohen, if you wanted to start with this. We know about the diagnostic odyssey. We know that there is a wait time. Could you elaborate more on the specific challenges that you've come across with your patient region implementing access and integrating genetic testing? What are specific to your region, and how have you been able to weave solutions into it as well?
Absolutely. So as mentioned, I'm at Children's Mercy, which is here in Kansas City, just a few blocks down. This hospital is also trying to serve a very wide geographical area, including all of Kansas. Just for reference, to drive across Kansas, it's about 9 hours. Any family in Kansas that has a sick child would be expected to travel all the way to Children's Mercy to receive care for that child. And I just find that unacceptable. And we have both a clinical testing lab for genetics here, as well as a research program. And so I'm on both sides, and I thought, how could I leverage potentially our research program to do some outreach? And so we decided to kind of flip the model. So traditionally, a family that lives really far away, if they're lucky, they will see a provider that might think this could be a genetic disorder and place a referral. And then they wait up to 12 months or more sometimes to see a specialist. Then they have to find, time off work, travel arrangements, childcare potentially for their other kids, and make their way all the way here to see a specialist who will then determine if they should get genetic testing, and then delve into whether there's insurance coverage and all of that, to then potentially get a diagnosis. And then once that happens, often they will have to come back here to get the specialist care that they need. We wanted to leverage our research program to flip that. So instead of coming here to just even get the testing started, what if we brought the testing to the families where they are? And so that's how we're partnering with primary care providers, so that hopefully the families can actually use the providers they already know to get testing initiated through our research program. And then ideally, in about 30 to 35% of cases, there's going to be a diagnosis. And that diagnosis will then be what's going to empower the family to kind of, speed through that wait list and get to come here, but already know what specialist care they're going to need. And just, I wanted to clarify, even though it's research testing, we have a very strong partnership between the research and the clinical sides, and I sit on both of those sides. So we do research testing, but then we do a clinical confirmation. So all the testing results actually do go to the patient chart and can be used to inform the clinical care.
Dr. Falah, what type of model do you guys have in your region with the access to care and the solutions that you've implemented?
Sure. So thank you so much for having me. It's a pleasure. Now, when I worked in West Virginia, a lot of patients will drive about 4 hours to see us. When we started the telegenetic service, we were wishing that we will have an improvement for those patients who travel 4 hours away to access to the genetic service. So telemedicine, we all thought that this is going to be helpful, but we kind of encounter a lot of challenges. So that is one thing, is that telemedicine could be improving, and we will talk about the challenges maybe in the next question. The other thing is the newborn screen. We all know that as early as possible to diagnose any disorder could be helpful to kind of find the diagnosis as early as birth, and then have the patient followed up by the genetic service. So that's another possible way of detecting disorders as early as birth. The other thing is having more geneticists in the area to cover more places. If you think about West Virginia, it's only one genetic center, or it's associated with academic. All the rural areas, suburbans, they don't have any specialists. That's kind of a thing that telemedicine could be part of, or give access to the patients in that areas. But we'll talk about the challenges that we have.
Dr. Abdallah, I know they're overlapping themes, but unique ones to your region.
Yeah, the themes are similar. There's kind of centralized expertise and outreach. With Montana, so Montana, just for the audience to know, it's the 4th largest state in the US, about 650 miles across, and about 90% of the region is designated frontier area. So frontier is more rural than rural, and about 80% of the population lives in areas that is, either that is all healthcare professional shortage area, a mental health shortage area, and some of those areas are really healthcare deserts where you even don't have access to internet. So the Montana genetics program is based at Shodair Children's Hospital. It's in Helena. And our model, just to echo what Anna earlier said, is a little bit different. We don't have an academic center. So it's an independent program that is based on outreach. As Anna said, we're trying to bring genetics care to the families. So we do outreach clinics in the different healthcare centers that are spread around the state. We do those once or twice a month. Travel clinics, so usually a provider and a genetic counselor travel together. And that's our core. Even in those outreach clinics, though, families often have to travel several hours because just of the spread. And then the other way we provide care is through telehealth. We might get to that later on. We also have a combined program, so we have a clinical and a laboratory program. As Anna mentioned, I think it's important to give access early on to genetic testing, and the genetic testing can be ordered either as outreach clinics through the clinical geneticist or clinical genetic staff, or from outside providers. And so various combinations of sequences then in terms of when you have a genetic test results, when you have an evaluation are possible. That's kind of our...
Yeah, good. So to kind of summarize the question, the answers that we have heard so far, one is integrating genetic testing with the primary care or the specialist in the outlying areas. And then the other one is actually having outreach clinics in those sites, as well as integrating with public health programs and newborn screening. So we've heard about 3. So the next question kind of ties in with that. Given the complexity of access issues, where do you think efforts should be focused to create the most immediate improvements in patient care? I'm curious to hear if you have any thoughts on where do you think you could get the most bang for your buck in terms of where should we put our efforts? And knowing that it will not address everything, but at least to get the ball rolling, because the subsequent questions will be about the post-test. But we're just talking right now, just to give the audience a flavor, we're just talking about just getting the immediate access to care, but we also have the post-test. But this is just to get the ball rolling on just even getting access to the first step of the process.
I mean, one thing we're really trying is to just get providers to recognize that a patient needs genetic testing. We're trying through our research program to make genetic testing trivial. It should be a no-brainer that you just do the most comprehensive test that you can, and it should be at no cost to the family. That should be the easy part, the testing. Because again, still only about 30 to 35% of people are gonna get a diagnosis in their first test. That's just the beginning. So really, but you don't get access to, whether it be clinical testing or a research study like ours, if no one connects you to that. So I really think investing in more diverse providers, not just the specialists, understanding that families might have a rare disorder in their midst, and connecting them to the correct providers, I think that's really where the biggest investment could be helpful to, especially to this community here.
Yeah, so if I think about the genetic clinic as before the patient reaches the genetic service, and within the genetic service and after the genetic service, the pre-visit is how those patients will reach us, and I agree that the referral is very important. Educating the primary care doctors is very essential here. We have a study that we published recently in the primary care journals, surveying primary care doctors or primary care residents actually, to see what is their insight about genetics, how genetic could be implemented in their service, and what's their thought about it. Interestingly, that some of the residents responded that they didn't even know genetic exists as a subspecialty, especially when you think about internal medicine resident, and remember that primary care is pediatric and internal medicine, family medicine. So some of them, they said, we didn't even know that it exists. They didn't even know that there is a rotation for that. So it's very interesting to see that they were satisfied with their genetic education in medical school. However, they were not satisfied about their genetic training. So if you think about when they are doing residency in pediatric and internal medicine, they rotate in different specialty, pulmonology, cardiology, but they do not have the knowledge or the good understanding that there is something else that exists. And it's an elective. So we noted that in West Virginia, not a lot of residents rotated in our service, which that's what created our interest to see what is the cause, and kind of evolving into the insights about their understanding. Now, genetic testing almost in every patient chart, and if you think about a primary care doctor doesn't know or understand that genetic testing, or they don't know when to refer the patient to a provider or to a geneticist per se, or to a genetic counselor, that's a big problem here. As I mentioned, the genetic education in medical school, it is evolving. If you think about the genetics in general, it's evolving. How many genetic testing are available, the presence of whole exome sequencing. However, the curriculum and training, it's still the same 10 years ago. Well, genetic has evolved in the past 10 years, and the education didn't evolve in the same manner where we have that. So educating the primary care doctors to identify, improving the training curriculum, that is an essential here for them to be able to pick up those patients that need us to be seen genetics and refer them to us. or to at least start with basic testing and then refer the patient to us. That is a key in identifying and improving the preclinic deficiency that we see, where patients, they're not referred, they are wondering, and we have now adult patients where they are diagnosed with adult onset Pompe disease, a condition that is treatable. Patient suffered muscle pain without having or without being identified early in life that could have been prevented. So anything that is treatable should be placed in the newborn screen, and we're glad that we see that Pompe disease, for example, is added to the newborn screen. And one last thing that I want to mention, genetics is not a pediatric only. If there is a pediatric, there is adults. So even adults, when they have a condition and they go to internists, they may not think that it could be genetic. And the worst here, when the condition could be managed, could be treated, could be prevented for adult individuals, including cancer, including muscle pain, including weakness, simple disorders or simple symptoms that may lead to someone to think about a rare disorders. In that situation, there is a lot of delay that we see.
Yeah, I want to really highlight what you just said, the awareness and the education. What you guys in the audience, the takeaway from the first two speakers on this is when you see a provider, spread the word around. We're doing our best with education, but as a provider, as a patient, as a candidate, as an advocacy organization is reaching out and just saying, do you think this could be genetic? Right? Get them to start thinking that, is it genetic, and have them reach out, go to Global Genes, go to your local genetics provider, just ask the question, could this be genetic? Doctor?
Yeah, actually, I would take that even a little further. As Nadia just said, the medical schools actually have evolved their training quite a bit. Johns Hopkins in early 2000, there's the Genes to Society curriculum that completely overhauled the medical school training for every medical student to have, with the requirement for each learning unit, to include some degree of a genetics part, basically, and Stanford, some of the other universities have done that as well. The problem is at residency. When pediatricians in Montana, we have a pretty strong pediatrics workforce, if you will. They're usually pretty in tune with regard to when to contact us, when to refer. The problem is that many in rural areas, the medical care of children especially is often not performed by pediatricians, but perhaps by family practitioners, mid-levels. And I know firsthand that there's absolutely zero education there. And to take that advocacy element a little further, it's not only asking your provider. I think that's why I'm excited that Global Genes, that we actually have this session here. I think there needs to be an advocacy on the policy level. The ACMG, the Geneticist professional society, has done some outreach, especially with AAP, but there are professional societies like the American Academy of Family Practice, for example, the Accreditation Council that regulates medical residencies and accreditation. There's very little input from genetics, and I think it's actually if professional organizations tell other professional organizations what to do, it's often problematic. But if advocacy groups do that, if it really comes from the public, that may change, yeah. And it's absolutely required in order to meet the needs now and really in the future.
Yeah, very good. So to summarize, the answers for that was education, awareness, and advocacy. How much of that, just a show of hands, resonates with this audience? I mean, did that seem new? Did anything that we mentioned, that genetics education, at least with medical education, has not kept up to pace with the advances in technology? Did that resonate with anyone? Was that new, or was that common knowledge? Common knowledge was the hand? No, didn't know. The other one? Yeah, okay. Good. Yeah, so those who are outside, from a patient perspective and an advocacy organization perspective, it's important to know that there's a gap right at the fundamental level from education onward. So awareness, education, advocacy were the key take homes. So now let's segue into the post-test. So let's say somehow the patient has gotten access to genetics either through the primary care physician, specialist, or through a genetic center. Now what? What happens next? So the next question is, post-test access continues to present a unique set of barriers. Explain in your work, what are the challenges that you have seen within your increased access for the post-test component, and what models of change have you implemented or recommend that we focus on for the next phase of genetics?
Absolutely. So in kind of that spinning things around and bringing a new model of access to testing that we've used in our program, we kind of fixed a little bit of the gaps by providing our own support system. So we're asking the providers to identify the families and to help us get the samples to us at no cost to the families, but we're doing all the other work. So we have our genetic counselor that is doing the pre-test, but also the post-test consenting. And that post-test and return of results consultation is very important, but it's only the beginning. And one of the problems we're finding is that it's really hard for us to sit up here in our little building and know what support we can offer families that are 3, 4, 5 hours away. And that is actually the big missing piece, is how can we connect to the different communities? What are the best partners that we can find? We have started identifying some community health workers that are, closer, maybe not in that exact town, but that are closer and might be a little bit more familiar with some of the resources. But for a lot of these families, it's actually going to take helping them in other ways to still potentially come here. And that might be support by actually arranging transportation, advocating for them with their jobs that they need time off. Whatever, unfortunately, I don't have like a magic way of fixing this, but it's really important to talk about it and try and come up with ideas of how to reach these families that post results, because the result, even though we're still seeing challenges getting to testing and getting to a concrete diagnosis, that is truly just the beginning for most families, and we're aware that a lot of struggles come after that.
I think the audience member had that question about what are the other avenues we need to explore. So that's what Children's Mercy has done with not just the increased access to testing, but connecting them with local community resources. And that I think with the previous talk I was listening, they had some really key words. Just the community resources is where, as globally connected as we are, pun intended, it ultimately comes down to what is within the community that we can access. So within the other avenues, it's just continuing to build that repository of information of what's available within the community, and the stakeholders within the community is what we need to do. And then Dr. Falah.
So to give you an overview about what we have done for improvement after the visit, this is specifically for telehealth, that we thought that this is going to help us or help a lot of patients access care even if they are distant from the clinic. We have noted that the patient arrived, great, had the referral, we saw the patient, we provided genetic counseling, patient agreed with genetic service or genetic testing, the recommendations that was given. And we have noted that a lot of patients, they do not perform the genetic testing, especially in rural Appalachia, where we had practiced before. So we looked into the numbers. We pulled up one clinic, which was the cancer clinic, looking into how many patients actually were able to return the genetic kit to the lab and perform the testing. And we have noted that about 50% of our patients were not able to get the testing complete after we shipped them the kits, which is a swab test that the patient will be able to send it back to the lab. We looked into the numbers, and again, 50% completed the test, 50% were not. And what we have done is we decided to do a QI projects to see what could be helpful. We implemented reminders in the system, 3 reminders, 2 by messages and 1 by giving them a phone call. We had an increase of about 10% on the patients that received the kits after we have that 50%. So it increases to 60%. We have about 40% that they did not complete the test. And the reminder kind of held. If you look at the statistical number, it was not statistically significant, but 10% of our patients really matters. So it's clinically significant. There's a lot of questions about why 40% they did not return these kits back to the lab. It could be barrier of education. It could be that they did not understand the full objective of the genetic testing. There could be they're not interested to have genetic testing to be done completely. So these, we wanted to kind of move on with more QI projects and calling these patients, interviewing them maybe in future projects. But it's important to realize that in rural Appalachia, there are some patients that they don't have a mailing address. Yeah. Others, they have issues sending it back to the lab. And then others may have issues with understanding the counseling part because of the disconnection while providing genetic testing with the broadband. The internet access was limited. And this was all cases that we kind of realized that they may impacted our testing, the test performing for those patients, and we wanted to address them on one-on-one basis. But definitely more QI projects are needed, not just with the genetic testing that is after the visit, but it's also for other recommendations for those who need us. Hearing screening or speech therapy or the other services that are recommended after we find a diagnosis, and I'll let Dr. Elias talks about that.
Could both of you also address, the genetic testing insurance issue? Because I know we had that. I want to incorporate that as we discuss the answers about the post-consultation process. Within your population, was insurance an issue, and did that factor into?
Yeah, so we have some subset of our patients who did not perform the testing that we found that they were concerned about the coverage itself. Although in general, genetic testing has started to become less expensive, but it's still not accessible or not affordable for some of our patients. We work with them in getting them some resources within the hospital, within the lab itself. They sometimes offer programs to help with that, but we still see barriers, and we see worry from patients that the test is going to be costly. And just to kind of address the insurance part as well, we receive a lot of phone calls before even the clinic that they are worried about how much the cost it is and how much it's going to be after they do the testing as well. And they call their insurance, and some of them, they reported that the code for the testing or for the visit was not covered. So we do see some barriers in that aspect as well. We don't have a data on how many of them, but we have some cases that mention that concern.
Yeah, insurance, I think one of the first things that comes up in terms of barriers often when we discuss these issues is insurance. So in Montana, and the challenge is that in each region, the challenges are somewhat different because each state has different insurance payer structures. So in Montana, we have the fortune that Medicaid actually does pay for genetic testing. Okay. About 50 to perhaps 60% of the patients we see are Medicaid. So that removes, I think, a significant barrier. Then on the payer side, the biggest challenge is among those patients who the provider, a primary care provider, for example, wants to initiate genetic testing, which we for example, in a child with neurodevelopmental delay, to get a microarray approved, chromosome microarray approved, which is a, for those, which is a study that looks at the chromosomes in much detail, and about 10 to perhaps 20% of children with neurodevelopmental presentation might have actually a diagnosis when you do a microarray. So it's a good and a recognized first-tier test. How do you get insurance approval there? The challenge is that if the provider offices have to do the pre-authorizations, there's often a breakdown. It doesn't happen, it may be denied, and then it stops there. So what we started doing is to have a pre-authorization support through our like a small we are a small program, small administrative team, hopefully soon to be enforced by a genetic counseling assistant to support the providers who ordered genetic testing with pre-authorizations. It's a sometimes complex process, but it actually has increased our ability to get insurance approval quite a bit. So that's one way to deal with that. We also have in Montana a fund that's actually through the state. It's administered through the Department of, so the DPHHS, or the Public Health, a fund, an annual fund to pay for genetic testing in patients who don't have insurance coverage for whatever reason. It has to be approved, and it's sometimes a little bit of a lengthy process too, but it's another avenue to do this. I want to kind of follow up on what Anna also said earlier. So what if you have then a diagnosis? So or if you have a test, then what do you do? The post-test, and I think there are two issues. One is result interpretation, and we've seen certainly in a rural context, not the same problems, but in a even magnified way. I think that providers who order genetic testing, who are not familiar with the process, the patients often didn't have genetic counseling. The providers are suddenly confronted with a result that they can't interpret, and that often creates a lot of anxiety among the families. It creates a kind of a pseudo-emergency situation often, and stress. And so the way how we try to address this is to kind of try an early access model where genetic counselor only visits can relatively quickly be arranged for such a situation. It's not perfect, but it has improved this situation quite a bit. My main concern really, and a growing concern, is okay, we have a diagnosis. How do we manage the patient? And I think this came up also from the audience. I think it's important to realize that most patients living with rare diseases that have a genetic diagnosis require multidisciplinary care. They often kind of fit the bill of a complex care patient, and to get this in a rural environment is sometimes extremely challenging. I think being connected to the community, so doing outreach locally, where you actually know who are your other referral sources, the other subspecialists, supportive services, and so on, can really help. But what we've seen in the last few years, especially in rural in states with large rural populations, is that there has been a systematic, I would say, deconstruction of public health services. And the idea is, I think, to decrease decrease the state, decrease public costs, but that has actually unintended secondary consequences. Just as an example, for years we had several community-based support services. So they do developmental evaluations, provide physical therapy, occupational therapy, and they contract with the state from their communities to get the funding. And just recently, many of these services in the different locations lost their contracts because this was outsourced through a private company, and now many families are struggling to get those services. So then we have a diagnosis, And we have a plan, but we can't actually execute the plan because the services are not there. And that really requires, again, I think that's why I think it's so important, your role, the role of organizations like Global Genes is so important to really advocate on the state level for these services. And I think there has to be a partnership with public health. Without that, I think we're really limited in rural areas.
No, awesome. This was, so to summarize for, where we've heard from the nitty-gritty of just getting the sample collected, you guys would be amazed at how much time, effort, and staff allocation we have to do in a genetics clinic or in a primary care. When it comes to implementation, just the logistics of getting a sample collected, like even in my own clinic, I have a genetic counseling assistant who spends more than 50% of their time just in coordinating sample, like tracking how many kits we've sent out, how many have been collected, because sometimes for the testing, you need both parents, so you need to coordinate that as well. So I don't know how much you all were aware that the logistics of the minutiae of implementation sometimes starts with just sample collection. And then we heard about the insurance, like having support within a clinic to do the prior authorization. So one of the things you may also be mindful of, keep your ears to the ground, is sometimes genetic testing companies can initiate, if they have a partnership with another company that does the insurance prior auth, sometimes the clinic will send it to a genetic testing company, and the genetic testing company will initiate the prior authorization. So that is something to ask within your community and your provider is, are there resources that we can leverage if a clinician's office does not have support, because prior authorization for genetic testing is a little bit granular. If they can't do it, can we send it to a lab that can initiate the prior authorization on behalf of the provider? So for the question in the audience, I don't know if the insurance testing was about testing or about management of services, but at least some laboratories do offer that. And then definitely community resources for the follow-up and working with public health organizations. So we're almost at time.
Could I just add something real quick on insurance regarding testing specifically? A lot of insurance is still behind in what they believe should be covered for genetic testing, and they're covering testing that is only picking up a very small subset of disorders, even though our field has repeatedly published data that is completely proving that you should be getting first-line testing, at least an exome, a whole exome sequencing, so looking at all 20,000 coding genes in your genome in the first test. And we're still seeing a lot of insurance companies that will say, no, we will not pay for an exome. You have to do either a microarray first or a small panel of genes first. And I think because there's a lot of advocates and parents here, this is a big push that needs to happen. You need to push to get the very best test that you have out there. And this is something that will also unfortunately need a lot of push in terms of changing, the law in what is minimal standard of care. And we actually published a study that showed that a lot of patients that got a small panel testing and then got denied further testing because that was negative, that we found a handful through our that were able to enroll in our research program. We found a diagnostic finding, and that time that lagged between getting the panel and then getting their diagnostic, there were interventions that could have drastically changed their outcomes.
No, to take off on that, what would that's a good point to wrap up, what would you do as kind of like a take home for this audience to do in terms of rural health and access?
Right, I think that it's very important to know your rights as well as to speak up when the genetic testing denied or your care is denied in general. One thing that insurance companies offer is a second opinion. You can always request that the test has denied, can I find an outside second opinion or an expert to look into this case. Most of the companies or most of the insurance companies, their policy has to be updated because genetic testing now is not investigational anymore. It's a part of the standard of care. It can be, we need to advocate for changing these policy and putting on guidelines. The ACMG has multiple guidelines to support the use of genetic testing. What is the first tier, what's the second tier? So these has to be part of all of the insurance policies, Medicaid, Medicare, for all patients to access testing. But if you get any denial, these has to be re-reviewed. Your doctor could provide you with a letter of medical support, which you also has to talk to and request these type of insurance, kind of a follow-ups. If it's not covered now, it may be covered in the next 6 months. So always follow up and do your best to get it done.
Closing thoughts?
Yeah, I think I want to pick up from what the previous sessions and some of the other previous sessions discussed about in the research arena, and that's where capacity building in communities is important. And I think this is not only true for research, but it's also true in the clinical setting. I think there are workarounds to get what you need in the specific situations. Shobana mentioned there are different companies that, for example, offer support to the providers in the pre-authorization, counseling, pre- and post-test counseling, but that does not, at the end, it does not replace the importance of having actually a local presence of someone who feels or who is responsible for this and who provides the support to the providers. So I think a regional presence of genetic expertise beyond just other models is really important. And I think, again, I think advocacy efforts are already helping with that. But we do, for those in those regions where we have just decreased, much less investment in healthcare services, such as rural areas, if you want to decrease inequalities and address diversity, we need to include regions, rural regions and rural areas, and hopefully are able to change policies in that way.
Good. We've got about 2 minutes, so hopefully this discussion generated some thoughts, questions, concerns. A lot of focus on the different types of models of service lines that have been used. So did any of that generate any questions for this audience? Or even if you just want to comment on what you learned, something that you didn't know was a possibility.
We actually have a question from our virtual audience.
Oh, yes, please.
Yes. Do genetic specialty care centers ever review a chart at the time of referral and request that the PCP order specific genetic testing prior to accepting the referral? Why or why not?
Sure, yeah, I can take a stab at that. Yes, definitely within the pediatric and adult clinics that I work in, we have. We try to triage clinically based on if it is, based on what we think the conditions could be. So if it is definitely something that a test that can be ordered, like if you have autism, very routine to get exome sequencing and a microarray, we will recommend that. If there's a child with autism, has seizures, other complications, we may say, no, it's probably best to come in. But the vast majority of cases, yes, depending on the clinical acuity, many genetic centers do consider that. I'm curious in your practice.
Yeah, we actually do that a lot, especially that for metabolic cases, we will ask the primary care to order the metabolic workup. So when the patient reaches us, we will have the genetic or the metabolic testing to be reviewed. There are other cases that we may request echocardiogram, for example, Marfan or EDS or other types of conditions to do an echocardiogram, or recommend preliminary testing. Then when the patient reaches us, especially that our wait time is more than 6 months. So these testing could give us an insight about the acuity and if we have to bring them earlier, accommodate them in or overbook in our clinic. So something that we usually do.
Any others? Any other different topics of interest? Take home for the audience, and we're right at time. Oh, sorry, yes, I see you.
Hi, thank you for the panel. I was just wondering, and this is not to be partisan. I mean, everything is political, right? But given the current climate, we're talking about diversifying clinical trials. Do you see, is there a strategic way to continue to try and make diversity, equity, and inclusion centered in the work that you do, given the fact that, for instance, in the state of Kansas, it's a very red state, and there are a lot of states that are really kind of pushing back hard on DEI efforts to the point where you can't even, have it as a part of discussion in schools or the work that's being done.
Now, Dr. Cohen, I know you've addressed this in your studies.
A little bit. I mean, we're trying to work around it by skipping, the official ways and structures are in place by using research studies and using, community health workers that are on the ground and might reach the families directly. We're kind of working around it. Is that ideal? No. Is it something that could be expandable to the whole country? Not without insane resources. Ideally, like I said, what would be great would really be that we fix the access to testing at a country level, and that becomes a non-issue, and then we could focus on the post-care. That's really what I would envision as a great solution.
Yeah, I would just add to that. I think diversity and inclusion is here to stay, and I think the ongoing efforts, I think eventually we will get there. Even though you're right, it has become a political issue. My sense is that there will be this kind of will equalize, and I think the importance is to push for that, to continue that. And I think that if we do this, especially if we do it on a local, regional level, where you really, rather than coming from above with policy, having a direct contact to the community, I think that can change minds too. So,
thank you.
Any others?
Thank you.
The lights in my eyes, so I can't see.
Thank you so much.
Oh, thank you.
This is a wonderful finale to our conference.
Thank you.
We just have one more goodbye, but we appreciate all of the insights you provided. Thank you.
Thank you. Thank you for having me.